Jeff Arrington was born and raised in North Ogden. He attended Weber State University, where he completed his undergraduate studies. He received his medical degree from the Medical College of Wisconsin. He completed a residency at Phoenix Integrated Residency in OBGYN in Arizona. Following residency, he completed a fellowship in advanced gynecologic endoscopy, sponsored by the American Association of Gynecologic Laparoscopists and the Society of Reproductive Surgeons. He has moved back to Utah and has been an instructor and co-moderator at the World Congress of the American Association of Gynecologic Laparoscopists. He is going to update us this morning on endometriosis. Thank you. I'll give you a 5-minute limit. You got to eat your full half.
See if I can figure this thing out. You know, I was watching Dave Allen up here taking the vote, and one key thing he didn't learn apparently from the time that his dad and my grandfather spent in the legislature is when you take a vote, you give plenty of time for the ayes to come. You ask for the nay vote and immediately move to confirmation before the nays can get their voice out. So he'll remember that for future. Endometriosis, non-malignant, not benign. This is a heading that I took from the last conference I attended with the AGL a couple years ago. Understanding when we think of endometriosis, we think of red blisters, blue-black lesions, blisters, maybe some early white blisters in the lining of the pelvis, associated with the uterus and ovaries, the peritoneal lining. What I want to go through today is we're going to focus a little bit more on the more advanced aspect of endometriosis, which really only encompasses about 10% of endometriosis cases. But those 10% can be dramatically different than what the common perception of endometriosis is. 10% of this disease behaves very much like a local malignancy in the damage that it can do, in the changes that it can make in patients' lives, more frequently in young patients' lives. These are women in their early to late 20s who suffer with a dramatically debilitating disease. And hopefully a lot of this that we'll talk about will show some new trends in the treatment of endometriosis, early detection, what we can do and what we need to be aware of as we move forward with this. I have no disclosures related to the topic. The objectives, number one, boy, it's hard to see from here. Understand the presentations of endometriosis and long-term complications, some basic research in endometriosis as a disease. Oh, I get help. Endometriosis is a disease, and understand the current advances and thoughts in medical management. We'll go over most of the common therapies and some newer ones that are being investigated, as well as the surgical presentations of endometriosis and surgical management. These are some examples, again, 3 examples of that more advanced disease. Clearly, these are not little red and blue and black lesions. These are patients that really suffer quite a bit. Hopefully I choose the right one. Thick blue-black nodules, but these are causing significant scarring. The bowel is pulled into the back of the uterus. The wall of the rectum is involved. This one here clearly what we call frozen pelvis, with everything socked together. The ovaries have large endometriomas in them, completely adherent to the back of the uterus, and as that peels apart, the sigmoid, rectal sigmoid, as it pulls in there, is stuck and adhered to the back of the uterus. These are some more of the more subtle lesions, not blue, black, red, red lesions, but here is just a simple white scarred lesion in the wall of the bowel. There's another one right up here. This is one where the deep rectum is involved circumferentially with endometriosis growing into the wall of the bowel. This picture here is the final product after the repaired removal of these lesions on the rectal sigmoid in this patient. Again, more pictures of the more advanced stuff. This is one that actually Bob Mosinger, the first colon or segmental colon resection that I did here for endometriosis on a patient we had come down from Oregon. This is the piece of bowel that Bob Mosinger took out for me with endometriosis, multiple. She had 4 or 5 of those lesions in the wall of the rectus sigmoid. A very subtle example of endometriosis up under the aponeurosis of the diaphragm. This one creating fenestrations, but there have also been full thickness endometriotic lesions in the wall of the diaphragm. Common symptoms of endometriosis, and the main thing that I'd like to go through or emphasize as we go through the symptoms and how to recognize disease, or at least how to raise a red flag. There's been a lot of push nationally that we'll talk in the next slide of how to increase early detection. A lot of the talk nationally is focusing on primary care providers, pediatricians, school nurses, so they know what to look for and how to counsel their patients and the students as they come in with the problems that they have. The dysmenorrhea, deep dyspareunia, pain with intercourse, dyschezia, painful bowel movements around the time of periods, chronic pelvic pain, and infertility is also a common presentation even without pain. This is a slide that shows an advertisement or poster board from the Endometriosis Foundation of America, endofound.org. There are multiple other Endometriosis Association websites that are available for patient and provider use for education. Again, this group here is focusing on early identification, patient and community education with the primary care providers and school nurses. The pelvic pain symptoms that they have typically are secondary dysmenorrhea, so the pain that will start a year or two or more after the onset of menses. The pain starts just before the menstrual flow, usually within the first couple days. There can be deep dyspareunia as well as catamenial sacral backache. Catamenial was a new word to me a couple years ago. Basically, it just means around the time of the period. Some organ-specific symptoms that they can complain of that may suggest the more advanced form of the disease: tenesmus, diarrhea, constipation, bleeding through the rectum, as well as dyschezia. The most common one that we find that's associated with actual bowel wall involvement is the pain with bowel movement. So even more so than blood in the stool, the pain with bowel movement around the time of period is more predictive of bowel involvement of the endometriosis. With bladder involvement, there can be dysuria and hematuria. Occasionally is confounded with interstitial cystitis and chronic bladder pain conditions. Also, with that right hemidiaphragm, that's the most common area I find it up in the upper abdomen, usually implants around the diaphragm on the right side. They can complain of shoulder pain and or scapular pain, occasional dyspnea. In advanced cases, patients will present with catamenial hemoptysis, which shows lung involvement. We haven't had any of those here, thank goodness. A few facts. The average time to diagnosis from onset of symptoms to the time when diagnosis of endometriosis is made in all comers is about 9.2 years. The pain does not typically correlate with the disease. I've had patients who the only reason we went in for surgery is because she had an ovarian cyst that wouldn't go away, get in, and there's endometriosis throughout the entire pelvis. Then there are other patients who have maybe 2 or 3 small spots that have significant pain during their cycles. So the pain does not necessarily correlate with the disease, and we'll go over that a little bit more. It is a common cause of pelvic pain, infertility, and painful periods. Early identification studies in adolescents. Dr. Coe, these are patients in their late teens typically. The average age or the average time to diagnosis in adolescent patients is 22 months, so just under 2 years. The number of physicians seen before the diagnosis is made in teenagers is almost 3. So a teenager going to 3 gynecologists is tough enough for as a teenager to go to 1, but to go to 3 before the diagnosis is made. DIE means deep infiltrating endometriosis. This is that more advanced form of the disease. Some markers that as we look back at school-aged girls, as they develop this deep infiltrating endometriosis later in life, these are some of the markers that come up through their school years that can raise a red flag. Periods that are bad enough where they need to miss school or work. Also using oral contraceptive pills for severe dysmenorrhea for less than 18 years of age. So under 18 years of age, if they're requiring oral contraceptive pills for severe dysmenorrhea, that can be a marker for advanced disease. Also, longer years of duration of birth control pill use, 8.4 years in patients with a deep disease versus 5.1 in those who have more superficial disease. Patrick Young out of St. Louis is pioneering a lot of the early studies in adolescent treatment of endometriosis. The most recent report he published looked at complete surgical excision in these younger patients and their pain-free interval. And it noted significant reduction in pain over 5 years in those patients who have early treatment versus those who have delayed treatment. A little bit of basic science regarding endometriosis. We look at endometriosis, the main thing that our patients feel and see is pain. And that's where part of the difficulty of endometriosis comes in, is there are so many other things within the pelvis that can cause pain. There are bladder issues, there are bowel issues, there are muscular issues, neuropathic type pains. A lot of this is responsible in endometriosis case due to the overproduction of prostaglandins. There's a local hyperestrogenic state in deep endometriosis that increases the estrogen supply. There's chronic inflammation and increased nerve growth factor. All of these things contribute to the pain complication and progression of endometriosis. One of the more interesting things that I've discovered, Dr. Linda Griffiths from MIT is doing research on the molecular level of endometriosis. One thing they have found that typically the most common belief of endometriosis origin is that there are implants, peritoneal implants, that implant in the peritoneum, potentially backflow from the fallopian tubes. But the question is, how do they break through that basement membrane in the peritoneum and become a deeper entity? There's an expression of a protein called MENA that is found in invasive breast cancers that is also expressed in some deeper endometriotic cells and loculi. And her research is focusing more on the cellular invasion, the ability of the endometriotic cells to change the extracellular matrix to allow them further deeper penetration into the local tissues. When we look at the pain aspect of endometriosis, originally and most often we treat this as a pain entity. There's an inflammatory response, there's acute bleeding within the belly. We treat this as a nociceptive, there's a chemical response or an instigator to the pain, and that's typically what we treat early on. There also is inflammatory pain. As you look at those initial pictures we show, a lot of the adhesions are responsible or due to the amount of inflammation that endometriosis causes. As these pain pathways continue, it can develop into more of a neuropathic pain. I've seen that a couple times with pudendal nerve injuries, or similar to, I like to think of it similar to reflex sympathetic dystrophy. So peripheral nerve injuries that if left untreated and left cared for can develop into more of a centralized nerve or pain problem. And I see this progression in a number of the more advanced endometriosis patients that I see. The longer they struggle with pain and the longer they go without control of the pain, the more difficult it is to completely treat their pain, even in the absence of endometriosis after surgical resection. We will talk a little bit more about some of the nuances and new things that we're looking at treating the pelvic pain associated with that. All the nerve growth factors, all the inflammatory mechanisms, they all come into play here in endometriosis. We'll skip through that pretty quickly. Fred Howard is one of the world experts in chronic pelvic pain. One quote that I pulled from him, I keep forgetting I have the monitor up front. Traditional approaches to treatment of endometriosis as a cause only of nociceptive pain are not sufficient. There's evidence that endometriosis may generate pain via inflammatory and neuropathic mechanisms, and treating patients with therapies directed at inflammatory and neuropathic mechanisms may be beneficial. We use NSAIDs, ibuprofen, Aleve. Some of the more aggressive ones, occasionally I'll use Toradol on patients around the time of their periods, or contraceptive pills, progesterone-only pills, levonorgestrel intrauterine device. This is an off-label use, but can be effective in endometriosis. GnRH agonists, aromatase inhibitors are some of the newer ones. And then neuromodulation goes into that neuropathic pain. A lot of the pain clinics are starting to use gabapentin and things of that nature to treat the neuropathic aspect of endometriosis pain. My preceptor, Dr. Liu, and the fellow that followed, I guess 2 fellows after me, did a paper looking at the predictability of response to oral contraceptive pill use in patients on the predictability of endometriosis versus no endometriosis. The gist of the study is if the patient responds to oral contraceptive pills or if they don't, if their pain improves during the use, it's really not predictable of whether or not there is disease within the pelvis. First-line agents that we use, especially in younger women, birth control pills, and again, with this, we're trying to control the pain that they go through. We're trying to allow them to function. We're trying to allow them to go to school and participate in their activities. Birth control pills are the most common first-line agent that we put at them. And we have them take them. We can either cycle them monthly, we can have them do every 3 months, we can do extended cycle. And the goal is to use the progesterone aspect of those birth control pills or potential progesterone-only pills to block the effects of the estrogen on the endometriotic disease. As we go through the medical options that we have, I think it's important to understand that we're not trying to get rid of this disease. None of the medical therapies are geared toward ridding the body of endometriosis. The most that they do is make them go dormant and allow the inflammation and the cyclical changes that go with that to keep it from proliferating as long as the patients continue to do well. ACOG in their practice bulletin regarding endometriosis states that if initial therapy fails, like the birth control pills, Depo-Provera, or medroxyprogesterone acetate, use the generic name of it. If those fail, then diagnostic laparoscopy to confirm endometriosis may be considered. It is a surgically diagnosed disease. GnRH agonists are considered to be the big guns of endometriosis. When all else fails, or you put the laparoscope in and it's just everywhere and horrible, you pull everything out and say you need to be on Lupron. The only problem, the main issue with that is Lupron can be effective in decreasing the pain that patients suffer with, but they are limited to, at maximum, 12 months of use. With add-back therapy, we've been able to extend that from 6 months to about 12 months to curtail the symptoms that they have with it. The only problem is once they come off the GnRH agonist, the disease is still present, it ramps back up, and it continues to be problematic down the road. Also, if it is deeply invasive disease, we look at that neuropathic aspect of pain. We look at the damage that is done to the nerves and to the deeper tissues, the scarring that takes place. Frequently, we find that the GnRH agonists and some of the big guns even though they make the endometriotic disease go dormant, it does not improve the pain symptoms associated with the scarring that's there. There's a risk of osteopenia. This may not be reversible after multiple courses. Currently, it's recommended to do no more than one course of the GnRH agonist and a high rate of recurrency. Again, the levonorgestrel IUD, the interesting thing that I found about this is a Cochrane database study looked at it, and as far as pain control, it's equally effective as the GnRH agonist with a device or a medicine that really you could use indefinitely. So there may be some benefit of considering an intrauterine device system treatment as opposed to the systematic GnRH agonist for long-term benefit without the side effects of the Lupron. I mentioned earlier about the local hyperestrogenic state of the deeper endometriosis. The aromatase inhibitors is an area that is being further studied a lot in the reproductive endocrinology world of endometriosis to knock down that aromatase activity in the endometriosis. Frequently we'll find that even patients who have had hysterectomy, have had ovaries removed, if there is still deep endometriosis, it can still be problematic and it can still proliferate and grow, and it's due to the aromatase activity in those diseases. Currently, the only recommendations I could find is that the aromatase inhibitors are reserved for those patients where all else has failed. Because there can be problems with osteoporosis, the hot flushes, and other symptoms that they feel while on aromatase inhibitors. One marker of note is ovarian endometrioma. This is a patient from St. George. This is her uterus down here. The endometrioma clear above the uterus, over the pelvic rim, contained a liter of the chocolate fluid. So just a massive endometrioma. Endometrioma as a marker of deep disease is suggestive of deep disease in about 60% of patients. So if there is a patient with an endometrioma, 60% of those will have deeply invasive disease. Endometrioma greater than 3 centimeters can affect fertility. There's two options of treating these. One is just opening and draining the cyst. The other is to actually open the cyst and peel the cyst wall out. Clearly there is a benefit of removal of the cyst wall. There is a risk of decrease in anti-Müllerian hormone when we're looking at fertility patients because some of the normal cortex of the ovary will be destroyed. But overall, as far as recurrence of endometrioma, treatment of symptoms, patients do better if the cyst wall is removed. Again, deep infiltrating endometriosis. This is a patient, again, with the low rectal disease. We saw her video, or the initial picture early on. This is a circumferential lesion of endometriosis. There's no way I can laser this off. There's no way that I can take care of that with bipolar cautery to burn it. There's no way even I can take care of it just by cutting out that section of endometriosis. It's so circumferentially involved. The only way to take this disease out, for me, is to call the general surgeon in, and we do a segmental resection around that primary reanastomosis, and most patients of those will do well. That we find the deep endometriosis in the rectovaginal septum. We find it growing in the wall of the bowel, large bowel, small bowel, in the pelvic sidewall, around the ureters, deep into the sidewall, the bladder wall. One of the more common areas I find it is the perirectal fat. We'll see an example of this shortly. This is a study looking at the benefits of what I call radical surgical excision of endometriosis. So not the lasering, not the burning, but actually going in and surgically removing the disease, making sure we get underneath the disease no matter how deep it is. The main things to point out here, these are before surgery, these are after surgery, the mean pain scores that we see. Clearly a benefit after surgical resection in all areas. With bowel involvement, again, the bowel alterations, whether it's diarrhea or painful bowel movements, significant improvement in those after segmental bowel resection or discoid resection of the bowel. This is a case report of a patient last year, 28-year-old, in a year and a half time, 5 surgeries, 4 pelvic pain and endometriosis. The first 2, lasering and burning of the superficial disease that was seen. The 3rd surgery involved a hysterectomy. The 4th surgery, again, was another diagnostic laparoscopy where the disease was seen and burned, in this case burned. And then finally, at age 29, her ovaries were removed. One thing I'd like to point out, this is the picture of the first surgery. Endometriotic disease along the uterosacral ligaments, burned. There's a little area of scarring. It's not red, it's not blue, it's not black, just a little bit of subtle scarring in the cul-de-sac. And we can see the progression of that over the course of the 5 surgeries, or 3 of the surgeries, going from here to an invagination in the peritoneum, a little bit of scarring starting under the rectovaginal septum, and then finally in the last one prior, all we see is normal peritoneum with 2 holes. And then the next slide will show what was developed. This is to the left side of the rectum. This is a video of the surgical excision, and we'll see here are those 2 holes that we saw previously. And as this continues on, you'll see how deep that disease tracked. I call this Swiss cheese endometriosis. As you get down in there, it becomes a cavernous disease that on the surface looks very, very normal appearing peritoneum. I tried to edit out as much of the boring part as I could. Hopefully it won't be too long. And this is just coming over the caudal surface of that. The vaginal wall is up here. The rectum is here medially. And the key to this is to only take out as much as we need to. As we peel this out and as this opens up, we'll see normal perirectal fat, that fat we want to leave behind, all the normal appearing tissue we want to leave behind, and separate this lesion from the wall of the rectum, from the pelvic sidewall, from the deep perirectal space, always using the assistance of a rectal probe so I know where my margins of the bowel are. The surgeon also needs to be comfortable in knowing that if they do get into the bowel, it's not a big deal. You treat it how the general surgeons would do. You do a primary reanastomosis, you just sew it back up. Most of these patients are young and healthy enough that they do just fine as long as we watch them and the incision heals appropriately. Again, good normal perirectal fat. Leave that with the bowel, take the remainder of the disease off. I just want to real quick get to the final aspect that'll show you how deep that tracked down in there. And there's the depth of the lesion. So here's the top of the bowel where we started roughly at this layer and how far that tracked in all the way really to the posterior aspect of the rectum in this patient. This one we're going to skip through. Basically, this is another patient with that similar kind of Swiss cheese cavernous endometriosis in the right side. We saw that dissection already. This is another patient with deep sidewall disease that required complete dissection. There's all the fun anatomy. I'm an anatomy freak. I love it. But complete excision of the peritoneum and deep structures on that right pelvic sidewall. Had the opportunity to go to do a relook in this patient about a year later, and this is how that healed up. Remarkably well for the amount of dissection that's done. It amazes me how well the body can heal with that, and with very minimal disease, residual disease. Again, this is another case of extensive endometriosis, a patient with frozen pelvis that I just blew through. This is one with an intramural rectal nodule, really not any significant evidence of disease on the outside of the rectum. The only way we found this is was by putting a rectal probe in and looking at the difference of the bowel wall. There's about a 2-centimeter nodule. As we'll look and see, it's deep to the longitudinal muscle of the bowel. You can see the longitudinal muscle pulling up here. We had to dissect in under the longitudinal muscle, and it was isolated between the circumferential and longitudinal layers. Open that up, pulled the nodule out, basically just do a reanastomosis on that longitudinal muscle, and patient did fine. Occasionally there will be full thickness lesions that are treated the same way. This is one again where the rectum is completely pulled in. There's circumferential disease there. There's no way to remove that other than to do a segmental resection. You free it up, get the bowel freed up above and below. I have the general surgeon come in with their stapler, or however they want to do it, whoever backs me up that day. Incise here, and remove the diseased wall in between and allow it to heal back up. The take-home points, again, the main thing is for this group is increased awareness of the disease to try to decrease that time to diagnosis aspect. The most advanced endometriosis I see are those patients in their mid to late 20s who since their teenage years have had birth control pills, and that one didn't work, so we try another one. And we try an IUD, or we try Depo-Provera, and we keep throwing different medicines at them without significant improvement in their symptoms. We get to their late 20s, and that one where the uterus is all frozen in, that's where they end up, or with the bowel involvement. We want to try to catch this earlier in hopes that by doing that, we make a significant decrease in the amount of this deep, debilitating endometriosis that we see. Again, it's not just blue, black, red and white blisters. This diagnosis is surgical. Even that being said, I do feel it's appropriate in initial patients presenting with symptoms to give them a trial of some of the more common medical therapies. And if it works, great, you keep them on that and let them go. Limited success and side effects of medical therapies. If it's not working, it's not working. We need to move on to other aspects. Deep disease is best treated by radical excision. And I think that's the end of my talk.
He'll stick around up here for a couple of minutes if there's any questions, but we need to kind of get people moving out of here. And at 10 o'clock, 9 o'clock? Yeah, 10 o'clock, we'll start the next session is the McCady Family Practice Residents presentations. So that's in the other rooms over here. Thank you. Thank you. Yeah, that was great.